Cardiovascular alterations, part 3 should be our last part. We need to skip ahead. Hopefully this will go a little bit faster because we need to get back to medications. And hopefully, if you have questions about any of this, you will call or email me about them. Getting there. Okay, medications. Cardiac glycosides. This is digitalis. Can be given as digoxin or digitoxin. Digitoxin is the oldest form. It's excreted in the stool. Digoxin is the most common form. It's excreted in the urine. So if you have somebody who's in renal failure, you should be giving digitoxin or very small doses of digoxin. And you need to make sure that you know how these drugs work, because we go by classifications, but these are all fair game. So you need to know about them because you've had pharm. So just a little reminder, if you have too much dig, you're going to have halos, you're going to have changes in your blue-green vision, you're going to have nausea and anorexia, and your your dig level is normal to be therapeutic is 0.8 to 1.8. And the digibind is its antidote. And to do that, you have to have a potassium that's at least normal or a little bit elevated, and you have to have a quite elevated dig level. Beta adrenergic blockers, or antagonists, all end in OL. These are your vasodilators, antihypertensives, antidysrhythmics. Inderal, non-selective, cannot be given to people who have asthma because it causes bronchial constriction. So non-selective beta blockers cannot be given to people with breathing problems. Your selective beta blockers are for your heart. They're your beta 1s because you only have one heart. Your beta 2s affect the lung. So, but when you're talking about beta blockers, you want your selective blockers to be given for heart disease. Your calcium channel blockers are like diltiazem, nifedipine, cardizem. Those are the oldest. There are some newer ones out there now. But they are vasodilators, antihypertensives, and antidysrhythmics. Your alpha adrenergic blockers or antagonists are also vasodilators, antihypertensives, and antidysrhythmics. Not used very often, but they are used. Drugs like Minipress are used a lot. Thrombolytics dissolve blood clots, or they're fibrinolytics. They dissolve blood clots. They can be specific or non-specific. Your anticoagulants prevent new clots from forming. Doesn't dissolve them, but they prevent new clots from forming. This is your Coumadin, your warfarin, or your low molecular weight heparin, or your heparin. I can't think of the name. Oh well. Antiplatelets prevent new clots from forming also. But there are things like aspirin or your glycoprotein 2B3A inhibitors. Your vasodilators are like your nitrates. They are a very potent vasodilator and work really fast. Nitroglycerin must be given sublingual. Your isosorbides are like Isodil and Sorbitrate, can be given orally, but they're in larger doses. And they also work extremely potently IV. Your ACE inhibitors given to prevent ventricular remodeling, Endinpril, have angioedema as a side effect. Your statins lower your cholesterol, and oxygen, please remember, is a drug, and you can only use it with a physician's order unless you have standing orders. Back to your fibrinolytics or your thrombolytics, just an idea. Back in, can't remember, probably about 5 years ago, in the 1980s, they developed the fibrinolytics and started using them more in the 90s. Streptokinase was the oldest, and the problem with it is it has a very strong chance of anaphylactic reaction if you use it a second time. So you can only ever use it once. But it's nice and cheap. It costs about $300. Where if you go to the newer drugs, your RPA or RTPA, they cost about $2,300. So they're a little bit more expensive. Genentech is the company that produces TPA and RNK, and they have said that there's no reason anyone should not get this if they cannot afford it. All you have to do is fill out the paperwork and we'll give it to you free. So that may involve some more work on your part, but it is very good on their part, but it's very expensive. Goal of care for somebody who has heart disease is to maintain your adequate pump function. You have to have an adequate cardiac output, which is 4 to 6. Cardiac output is determined by taking your heart rate by your stroke volume. Factors that affect your stroke volume are your preload, that's your ventricular volume, think of it that way, that's the easiest way to think of it. Your afterload, which is your systolic blood pressure, or the pressure against which the heart must beat, and your contractility, which is affected by Starling's law. And you need to maintain adequate tissue perfusion. Some possible reasons for decreased cardiac output is that you have decreased oxygen to that heart muscle, maybe because of a vasospasm, atherosclerosis, decreased contractility of that heart muscle from a heart attack or cardiomyopathy, a decrease in preload or an increase in afterload, like if you have somebody who has hypertension, if you have valve disease, stenosis or insufficiency, or you have somebody who has severe CHF and fluid is backing up rather than going forward, can all decrease your cardiac output. Decreased heart muscle contractility or pump failure is oftentimes due to ischemia or necrosis of that heart muscle. Cardiomyopathy, remember Starling's law, the bigger it gets after a point, the less well it contracts. But if it's not big enough, it doesn't contract well either, so there's a finite space in there. Fluid volume excess or dysrhythmia. With a dysrhythmia, you lose your atrial kick if the atria are not contracting well, and so that's about 15 to 25% of your cardiac output. Or you could have a tachycardia where you don't allow those ventricles to fill fully, and that's going to decrease your cardiac output. If you have an increase in demand, such as thyrotoxicosis, where your thyroid is overproducing and overreacting, and your basal metabolic rate is way too fast, or if you're pregnant and you're working for 2 or more, if you have obesity, hypertension, a sudden increase in activity when you're not used to it, or an increase in your basal metabolic rate, anything that like a fever causes an increase in demand. Reasons for decreased tissue perfusion might be a decrease in cardiac output, atherosclerosis, an occlusion, either arterial or venous. Now remember, venous is going to be related to Virchow's triad: venous stasis, injury, and hypercoagulability, putting your patient at risk for a DVT. Common calls for nursing for somebody who has cardiovascular disease. You might have a decrease in cardiac output. These are all problem statements, and they're just to name a few that I'm listing. Decreased cardiac output you can deal with as the nurse. You can affect their fluid status, which will affect their cardiac output, or you can affect their rhythm. So you can make changes in decreased cardiac output. Decrease in tissue perfusion, peripheral or cerebral or coronary. You need to identify where. Activity intolerance, anxiety or fear, acute pain, altered family process. They're no longer able to do what they used to do. Denial, which is sometimes a protective mechanism. Grieving over what they've lost. Altered sexuality, because you can't forget that. And these are just to name a few. There's a whole bunch more out there. One of your favorites is always knowledge deficit. That's a good one. Altered role performance is another one. Maybe altered home health maintenance, who knows? But these are just problem statements to name a few that you might be dealing with as a common call for patients who have cardiovascular disease. Your usual goal of care is to decrease the workload of the heart. So I give beta blockers, put them on bed rest, and give them supplemental O2. You want to increase myocardial oxygenation. Again, supplemental O2, decrease their workload. Don't have them overextend themselves. You want to improve tissue oxygenation, so you may have them in bed and gradually increase their activity. You may elevate the legs or do things, give them EPC cuffs or anti-embolism hose, Job stockings. Decrease fluid volume excess or deficit. So you're going to either give them fluids or limit fluids. Have them on I&O, daily weight. And you want to increase their activity tolerance so that they do tolerate activity better. You want to make sure before they go home that they're able to climb, say, a flight of stairs without chest pain, particularly if the bathroom's downstairs and the bedrooms are upstairs, or vice versa. One way in which you do some of these things is enroll them in cardiac rehab programs. Phase 1 is in hospital. Totally. It starts when they come through the door. It includes exercise and education. It is totally monitored. The process is mainly to educate and then get them up to 3 mets of activity. And by 3 mets of activity, I mean they're using metabolic equivalents of oxygen. So it takes that amount to, takes about 3 mets of activity to get in and off of a bedpan. So you don't necessarily want to use bedpans right away on your patient. It takes less stress to put them up on a commode, which you need to get a doctor's order for. Phase 2 is post-hospitalization. This again is still monitored. They're on telemetry, and it's usually associated with a hospital facility, or at least with physicians. And it does include both exercise and education, because remember, patients remember maybe 20% of what you tell them. That's why you give them so much written. And so you have to repeat all that stuff. Phase 2 does include family, and the focus is more on lifestyle modification, gradual resumption of full activity, social support, maybe getting them back to work. This usually starts about a month to 6 weeks after the MI and continues for another 6 to 8 weeks. This can be expensive, but it also can be covered by BVR, the Bureau of Vocational Rehab, because these people sometimes need some retraining so that they can get back to work to do what they were doing before or something similar. Phase 3 is community-based. This is not monitored. It's basically social support with some education. We have the Mended Hearts chapter, the Glass City chapter of Mended Hearts, which is chapter 100 in this area. It includes patients who have had pacemakers, heart transplants, bypass surgery, all sorts of cardiovascular disorders, and they have fundraisers and they meet once a month, and they're very much service oriented. And keep in mind that most cardiac patients are type A patients, so they're very well motivated and out and about and doing things. And the reason I mention them is they're a great source for scholarships for nurses. They love nurses, and they can give you scholarships when you go on for your baccalaureate degree. So think about that, particularly if you're going to do anything in cardiovascular, which, in case you can't tell, I really like. This is talking about normal conduction of the heart muscle, normal conduction of the impulse for the heart. It starts in the SA node, which has an intrinsic heart rate of, hopefully you filled in 60 to 100. It then travels down the different bundles in the atrium. You've got 3 on the right and 1 on the left, basically, that goes to the AV node. The AV node has an intrinsic heart rate of, hopefully you said 40 to 60. And then it travels down the bundle branches. You have 1 on the right and 2 on the left, and to the Purkinje fibers and the heart cells. And the ventricle has an intrinsic heart rate of less than 40. References say 20 to 40, but I have seen patients who have heart rates of 16 and they still are aware, kind of. They're not necessarily making sense or doing a lot of productive work, but they are aware of the fact that something's going on around them. And so basically anything less than 40. This is showing the action potential and the EKG. You've got down below, you've got the normal EKG. You've got your P, which is your atrial depolarization. Your PR interval is when the atria contract. Your QRS, which is ventricular depolarization. This is your absolute refractory period. At the Q, you've got, and the action potential goes from 0 to 1. And in that 0 to 1, you have sodium going into the cell and potassium coming out. And by the time you get up to 1, potassium's going back in the cell and sodium's coming out. This is your absolute refractory period. Phase 2 is when calcium, that's your plateau phase, and calcium is going into the cell. This is when the body and the heart will not respond to anybody else. It's like you want to go to the prom, and you've gotten a request from Tom Cruise, George Clooney's still single, so George Clooney to take you to the prom. And he's somebody you really, really like. So he's asked, you're going to go. You're absolutely not going to listen to anybody else. Well, then you got phase 3. Calcium's coming back out of the cell. And this is your relative refractory period. The ventricles have contracted. They're relaxing here. You have a T wave. And here, well, you might make a change in your mind. Maybe you just got a call from Prince William. And he really wants you to come to England for his due at the palace. And he's going to pay for you to fly there and do all that. Well, gee. I had to think about that. George Clooney? Prince William? I might go with Prince William. I might make a change here. It's a little dangerous now, though, because, gee, I could end up with nobody. Or I could cause an international incident, right? So the relative refractory period is really a dangerous time frame. Because if an impulse fires here, it can cause a run of ventricular tachycardia, which is lethal. And it's called torsade de pointe. And it can kill your patient. Not something you want. Phase 4 is where everything returns to normal. And this is your non-refractory period. Now, you'll go with whoever calls. You don't care. Whoever calls you, you're going to go because you really don't care. And it's not going to cause a problem. This is what your ECG paper looks like. Each teeny tiny square is 0.04 seconds across in time. And it's 1 millimeter up in distance, or 1 millivolt, but 1 millimeter. Each darker square is 0.2 seconds across and 5 millimeters in height. So your normal intervals, as you can see, there's another little box. Your normal PR is 0.12 to 0.20. Your normal QRS, which starts at the Q point because you rarely have a Q wave, and goes to where the S returns to the baseline, is 0.10, 0.04 to 0.10, or less than 0.12. Your ST segment is normally isoelectric, or a lovely straight line, and your T wave is normally upright. If you have a U wave, remember it indicates either potassium or magnesium that is low. Well, your R to R interval, you count the number of teeny tiny squares between those boxes and divide it into 1500 to get a rate, and that will tell you your patient's rate, because there are 1,500 teeny tiny squares in 1 minute. Again, looking at your QRS complex. You also need to measure your QT interval, and you need to look at that. That's from the Q point to where your T returns to the baseline, because that will help you determine if they're getting too many or too much too many medications that are prolonging the refractory period, or if they have an electrolyte imbalance that you need to treat. Because if the QT gets too long, you put your patient at risk for sudden death. I don't like my patients dropping dead on me. And if it's too short, you may have a problem also. Not sudden death, it's not as severe, but you may have an electrolyte imbalance, particularly your magnesium. This is just showing some different arrhythmias. The one at the very top is a regular sinus rhythm. The one next one underneath it on the left is an atrial fib. Atrial flutter. The one under it is an atrial fib. And the one under that is another fib flutter. You've got ventricular tachycardia, or an SVT. I'd have to measure it to see which it is. I think it's an SVT because I see P waves. So it's an SVT in the top right, and under that is VTach going into VFib. So here's a regular sinus rhythm, RSR. Remember, I don't like the word normal because it doesn't really tell you anything. A regular sinus rhythm tells you that this is regular and that it's initiated in the SA node and everything's there that it's supposed to be. And this rate is 5, 10, 15, 19, 20, 21, 22, 65. So we have an atrial regular sinus rhythm at 65. Your PR is 0.20 to 0.24, so you could have a little bit of a first degree AV block here. ST segment looks a little depressed, but it's less than 1 millimeter, so that's okay, and your T wave is upright. This is a sinus bradycardia with an IVCD because your QRS is 0.12. But the problem with this is the rate is slow. Again, if you count the number of complexes between R to R, you've got 5, 10, 15, 20, 25, 30, so you have a heart rate of 50. You've got a Q wave that's about 3 millimeters deep, so that tells you that you have had an MI at some time in their life. You cannot tell whether it's acute or not. ST segment is slightly depressed at 1 millimeter, but that's not clinically significant. And your T wave is upright, so that's normal. So that's an old MI that you see there. This is a sinus arrhythmia or a sinus dysrhythmia, where you've got an inspiratory rate that's one rate and an expiratory rate that's another. It slows down on expiration because of the change in intrathoracic pressure. Everyone does this. This is totally normal. It means absolutely nothing. You just need to identify what the two rates are. This is again showing a regular sinus rhythm with a first degree AV block. It's a little bit longer, a little bit clearer than the one at first, because you can see that this PR interval is 0.28. This is showing a sinus rhythm with a second degree AV block, type 1, or Mobitz 1, or Vinke-Bach. And that's the way I would chart it, is that they were a sinus rhythm with a second degree AV block, type 1, because it's shorter. And then I would note that we had 3 to 2 conduction, because you have 1, 2, 3 P waves, and you have 2 QRSs. This is what your T wave looks like. You always have to have a T wave if you have a QRS. You do not have to have a P wave to have a QRS. So there's your T wave followed by a P. With a Vinke-Bach or Mobitz 1 or type 1, your PR gets progressively longer until 1 is dropped. So if you look, you'll notice that the first PR is like 0.2, and the next one is 0.28, and then the next one is dropped. Then we go back to 0.2, 0.24, and then dropped. Okay? This is a classic Vinke-Bach, which is again your type 1 or your Mobitz 1. And this again is showing, the first one is showing 4 to 3 conduction, the second is 3 to 2, then we go back to 4 to 3. You have a PR that gets progressively lengthened, and then the QRS is dropped. This is a lead 5. This is showing a sinus rhythm second degree AV block type 2 or a Mobitz 2. And with this one the PR stays constant, but then you still drop a QRS. You still drop a QRS. So you can see here that your PR is 0.22 to 0.24, and it stays constant throughout. This is an atrial fibrillation with a wide QS complex. You don't normally have a wide QS complex, but this one happens to be. It is because these are real patient strips that I've pulled off for most of these. So this is an atrial fib. You'll see you have a wavy baseline. You do not have an identifiable P wave for every QRS, and it's irregular. This is an atrial flutter, and if you look at it, you will see a soft-tooth waveform, where if you cut off the R and the S waves, it looks like the blades of a saw. It tends to be irregular. You have an atrial rate here of about 300 and a ventricular rate of about 70. It varies because it will always be irregular with an atrial flutter. You want to know what your atrial rate is because you don't want to conduct one-to-one. Atrial fib, atrial flutter, main problem is blood will pool. It decreases your cardiac output and increases your risk for embolization. Complete heart block, medical emergency. QRS is 0.12. If you look, so we have a ventricular rate here of 19, I think, if you look, and we have an atrial rate of about 70. Yeah, about 70, and the P waves have no conduction, no correlation with your QRS. That is not a PR interval. It's not paying any attention to it. That's a good clue if your PR gets progressively shorter, that it may be an AV dissociation, and a complete heart block is a type of AV dissociation. This is ventricular tachycardia. This is a patient who, at the beginning, is in an atrial fib, and then this is ventricular tachycardia, and if it has a pulse, you would cardiovert or give a drug. If it doesn't have a pulse, you could defibrillate as the different treatments. But this is ventricular tachycardia. This is showing torsade de pointe. With this one, we have a patient who's in a sinus rhythm here, has a PVC, close to that beat, another sinus beat, another PVC going into VTach, and then into VFib. That's torsade de pointe. This patient was countershocked and did survive. And this is artifact. Looking at this, I think I can see 4 QRSs, but I can't tell you what this patient's rhythm is. Anytime you see this, you have to go check your patient, change your patches, get rid of the electrical interference that might be causing it, or the patient. I had a patient that looked like VTach once, and he was all the way down at the end of the hall. They always are all the way down at the end of the hall. And it looked like VTach. Well, I'm not going to run that distance by myself, check my patient, come back and get the crash cart, call for help. I took the crash cart with me. So as we're going down the hall, I'm going down the hall with the crash cart. Other nurses see me with the crash cart. What do? They come along. So that by the time I got down to 17 to go into the room, I had 6 nurses with me and a respiratory therapist. And I pushed this into the room, and I walk into the room, and there's the patient tapping his chest over one of the leads. And he stopped doing it. And he says, "Oh." I said, "Yeah, you might not want to do that. You obviously have more help here than you know what to do with." He said, "That's right. But it itches. If it itches, when they take, you can change the patch location. Tell them not to scratch at it. Use the pads of their fingers and rub it. Because what you've done is you've removed the top layer of skin, the dead layer of skin, and sometimes that becomes irritated and will itch. So you want to make sure they don't itch it, because that can really abrade that surface and make it much more painful. This finishes the cardiovascular lecture. If you have any questions, please contact me. If you have strips you want me to look at and interpret with you, I'm more than willing to do that. This is, I think, one of the most fascinating systems that we're going to deal with. Let's face it, without it, we're dead. So you really need to understand this. And if you're having concerns, please see me. Thank you very much.